Good morning. Steve Stites, Chief Medical Officer here at the University of Kansas Health System. Delighted to be back with you on this improved weather Tuesday morning where we expect to see a little more sunshine and hopefully no more tornadoes in the Kansas City area. I am joined today by, of course, Doc Hawk here on my right and the Secretary of KDHE, Dr. Lee Norman. We are delighted to have you back with us today, sir. And we are also joined by Jen, how did I say it wrong this time? Villwock.
Villwock, yep.
Jen is one of our outstanding ENT surgeons here and does a great job. And she's going to talk a little bit with us about long haul and the loss of sense of taste and smell. And we've had some questions about that, so that'll be a fun conversation. But first, I'm going to turn to Doc Hawk.
Hi.
What's the good news for today?
Numbers are still pretty good.
Okay.
Still pretty good. You know, looking at the Kansas City area, acute infections, it's still just hovering just below that 120, which it was lower. It was under 100 at one point. But here at KU, at University of Kansas Hospital, we have 11 acute infections with 4 in the ICU and 1 on the ventilator. Still have 15 in that recovery period as well. So
still a lot better than what we had.
Not
as good as we were down to 5, but still quite good and stable for a couple of days.
Yeah, and Hays is still doing well. 3 total with 1 acute infection and 2 in that recovery.
They've really done a lot better. I mean, they were up to 30, 40 patients, and so that's got to be a relief for the good folks out in Hays, Kansas. Hey, real quick, AstraZeneca kind of in trouble, I think.
Yeah.
What do you think? I mean, it got bumped again by their home country, where it was made or was developed, and multiple other countries in the European Union around this clotting issue.
You know, I saw Boris Johnson. You know, for what it's worth, he still said it's safe and effective. You know, in the UK, but World Health Organization is still endorsing it as well. So let's get all of the data. Let's vet it very well, because this is one more thing that we need if it is proven to continue to be safe. So.
Lee Norman, are you getting nervous about the AstraZeneca vaccine data at all?
Yeah, I am. I mean, much like Dr. Hawkinson said, we need to get to the bottom of it, because if we're going to eventually have it as one of our armamentarium, we want to make sure that we're basing that on safety data and efficacy data, just like the rest of them. We hate to have something that's hard to sell, quote, to people. We want to make sure that it's a good one.
Yeah, for sure. Well, let's turn real quickly. We know there's going to be some questions from reporters. I'm going to bet this morning. What do we got? Cody and Taylor are not here. I'm going to talk to Lee Norman. Lee Norman, talk to us about the big announcement yesterday from the state of Kansas moving a little further down the vaccine road.
Yeah, the governor and I had a press conference yesterday afternoon where we announced that we'll be moving on Monday of next week into a combined phase 3, phase 4. As we've marched along through this, there's many counties that have already finished phase 2, which has then allowed for the shifting of vaccine over to other counties. Everybody's not done with phase 2, and those, and particularly the larger counties that are not done with phase 2, will still emphasize and prioritize those people. But phase 3 and 4, and I've heard from a lot of medical people and associations around the state how very difficult it would be to separate out those people with severe medical risk in the 16 to 64 age group from, quote, other medical risk. The CDC does provide guidance on that in what they call their conclusive data and information list for the severe and the other medical risk conditions that might be at increased risk. But when you look at it as a doctor, or you look at it as a person with those risks, there's no bright line that separates a lot of them. Why would type 2 diabetes be in 3 and type 1 in 4? And you know more about this than I do, Dr. Stites, why would cystic fibrosis be in 4 and not in 3? So some of them just became not so much for debate, but just how do you do it? So we decided, with the increased vaccine coming to the state, that we're just going to put it out there. And I think it's a really good time for people to touch base with their medical care provider, to talk with them about the vaccination, whether they end up getting in their medical office or they get referred to one of the vaccination sites. So very excited to be able to move on. There's been a lot of people chomping at the bit, and we do know that there's people that have not gotten it yet that are absolutely great candidates. I'm thinking of the 18,800 actively being treated cancer patients and hematologic malignancy people, for example. We know they're at risk, and we're going to be glad to vaccinate them.
Dr. Norman, I'm right there with you, and I'm delighted 3 and 4 are being combined because I couldn't figure out quite as a healthcare provider how I could justify the very ones you were mentioning. In fact, for our CF population, I was thinking, well, they technically have chronic obstructive lung disease by the gold criteria, so I was just going to push them into that category.
Yeah.
But the truth is, I think this is a much better approach because it opens up. How are we going to just be asking patients that, or just relying on their telling us or the physicians giving us a little history? How do we judge who has what disease?
Yeah, so really it puts pressure on the vaccination sites county by county to say, how do we know? Are people going to act in good faith? I think it would be best if people would bring proof, if they have a pill bottle or something that more than just, yes, I have asthma. Some people have asthma when they're a kid and haven't had it since. I would like to think that people will really require actively being treated illness or diseases and not just a history of. For example, there's 180,000 people with a history of cancer or are cancer survivors, and but that doesn't put them at increased risk. So I do not think that they would be a person with that kind of a medical indication for having it. So the question, and we'll come out with guidance between now and Monday that says, here's what we think is a reasonable approach. Again, I think that it would be a really great time for people to touch base with their physician or their primary care or their specialty providers to really make a case for having a vaccine in phase 3 and 4. Smaller counties, it's easier. People tend to know each other. Bigger ones will be a bigger issue.
It sounds like a lot of it will be just based on personal responsibility, people trying to do the right thing. Is that your sense as well?
Yes, I think it is. I think that people have acted in good faith. Everybody knows of somebody that's jumped the line, and nobody thinks that that's the right thing to do. And sometimes they don't have even that right. There are people that have hung around vaccination sites toward the end of the day, and even though they weren't in that particular phase, because it was the end of the day, there were a few open appointments left. They said, "Come on in, let's get you vaccinated." That's not jumping the line. That's making good use and not wasting vaccine. So we do rely on the spirit of fairness and honesty, and proof is also good, though. If people can bring something.
Yeah, you bet. And then, so talk to us a little bit about what you think is going to happen with the supply of vaccine and who's going to be doing the vaccinating going forward.
Yeah, both good questions. The vaccine supply, we're going to get a big influx of the Johnson & Johnson product at the end of this month. That'll really open things up. But as a one-time deal, we don't really have great assurances as to what the J&J product will do. We think there'll be a steady increase in the amount of vaccine coming from the Moderna and Pfizer as well. Again, these things, we've had to be nimble and adjust, and all the vaccinating sites have as well, with every now and again, whether weather or something else related canceling. But we hope that there'll be a continuous increase. Keep in mind, we've increased the weekly vaccinations by threefold already. You remember back in the bad old days in January where we had 40,000 doses a week. Now we're over 140,000 doses a week. So we're getting the vaccine into arms, and I think that though to predict it with a great deal of certainty from 1 week to the next is a little bit difficult with the supply chain coming from the feds.
So do you have a sense, though, is it going to still be through the counties? Do you see, I know the pharmacies, that's through a federal program, have escalated a bit. How many doses are the pharmacies getting in Kansas every week?
It's a very small percentage, Steve, of the overall. I didn't see what the number was this week, so I can't give you that. I can give it back to you, and you can report on it tomorrow. But to your original question, I forgot to answer it. Is yeah, we're going to open up more provider sites, including medical practices, primary care, and additional pharmacies, because we have over 1,400 vaccinating sites that have registered, but probably half of those haven't even been turned on yet. And the reason is there haven't been sufficient vaccine. I personally think that it's really critical to get vaccine to medical practices and where people can rely on their physicians and primary care providers and others to talk with them about it and then to administer it there in their office. The Johnson & Johnson product is ideal for that. It's easier for medical practices to handle.
Well, and for those of us that practicing with more chronic disease patients, it would be what a great place to do that vaccination of some of the most vulnerable populations in an endocrinology clinic or a pulmonary clinic. Not that I'm trying to run an ad there or anything or campaign. Look at the guys. He knows me too well. There's been too many years there. All right. Well, thank you for being here this morning. I want to talk to Dr. Villwock for just a moment. I'm going to get this right. I swear I am before the end of the day. Okay. You're part of the long haulers clinic, and you're seeing patients who have lost their sense of taste and smell. So how's that going? Are people getting it back? Or tell us a story.
Yeah, so, I think loss of sense of taste and smell really hit the news several months ago, and I think that really put those constellation of symptoms on everybody's radar.
I think it came out of the ENT world that people were
Yeah.
seeing, and I believe that was with the first publication. I remember your chair talking about it a little bit one
Yeah,
time.
and so what we know from a lot of that early literature is that loss of sense of taste and smell can be a first, sometimes the most prominent, and sometimes the only symptom of COVID. And what we're seeing now is kind of the after effects of that. And we know for the majority of people, sense of smell and taste will recover, but not for all. And when you think about how many people have been impacted, it makes it a huge, public health issue going forward.
Yeah, it really does. So does it get better eventually, or does it stay bad, stay gone?
So for most people, it does get better. So for those that completely lost their sense of smell, meaning couldn't smell a darn thing, 6 months down the line, about 20% of them still have loss of sense of smell long term. And we just don't know what's going to happen, years from now. But there are, a significant amount of people that still have that smell loss. For those where their sense of smell was decreased, but it wasn't gone all the way, the numbers actually are a lot better. About 95% of them recovered during the course of 6 months.
Yeah, well, that's encouraging for those. I hope somebody gets. Well, why do you think in some patients it just doesn't seem to come back?
Yeah. So there's two thoughts. So a lot of viruses, coronaviruses as well, but flu virus, can also impact sense of smell, and it can happen in two ways. One is just direct inflammation, kind of where the smell fibers come down into the nose, so you get the stuffy nose and everything, airflow is blocked, there's inflammation. But some of these viruses also like to attack nerves, and the small fibers that are coming down from your brain are basically direct little nerve extensions. And so if those get inflamed, and sometimes it can cause, death of some of the neurons in there, that also leads to, some of this more prolonged sense of smell loss.
Yeah. Do you think it'll eventually come back over a period of years? Do you think so we'll be left with no sense of taste or smell?
So what we know from studies that have been done in folks that have lost their sense of smell from other viruses is that it's better to kind of be actively engaged to try and retrain your sense of smell.
Okay.
And so there's been a number of studies looking at things like supplements. So there's some good literature supporting omega-3s or fish oil. There's been some studies that have tested other things where the results haven't been as strong. But really what tends to be the most helpful is olfactory training. Almost thinking about
So
it.
I can train my nose to smell better?
You can train your nose to smell better, even if you don't have loss of sense of smell to begin with.
Really? Okay,
Because-
so how do you do that? 'Cause-
Yeah.
Yeah.
So it's essentially, known exposure to known odorants, trying to really reinforce, that smell detection and identification.
Okay.
And so the way that I explain it to patients is almost imagine that the hardware is there because we know that the smell nerves are unique and that they can regenerate. But something has happened, and now we need a software upgrade. And so the software upgrade is the retraining. And the basic protocol is essentially every day, twice a day, you smell at least 4 things, and you recall as you're smelling it. All right, brain, even if you don't perceive anything, you would say, all right, this one's lemon. Get ready for it, brain. Remember what lemon smells like. And then you're going to smell it. And it sounds kind of wonky, but it does, the results are actually pretty strong. Less strong for coronavirus or for COVID, but better for some of the other upper respiratory tract infections, flu virus, et cetera.
What about for those of us with allergies who have been on nasal steroids? Does this work for those of us? Okay, so I'm that person.
Wow.
So
Yes.
does that help too?
It was sounding like you might have a vested
Yeah,
interest.
yeah, it may be.
Yeah, so
For a friend.
yes, asking for a friend. Yeah, so those of us that do have allergies, I also have allergies and use a nasal steroid. Nasal steroids are great, and so they help to control some of that
They are
inflammation within the nose. And so if that's contributing, that will help. There's not a lot of great data, supporting their use just as a therapy in general for smell loss. If we've confirmed that there's no inflammation when we've looked inside your nose. But, it's one of those, if it were me and I had lost my sense of smell, from COVID or one of these other viruses, it's something that's relatively low risk. I mean, I think it's worth a shot.
Yeah. All right. Well,
What
that
about
sounds pretty
maybe
cool stuff.
sticking your nose in a coffee cup or?
Yeah.
wine glass?
Yes, so, in terms of the smell retraining, there are commercially available kits. However, some of those are kind of pricey. And so what I recommend to my patients is, you don't want to be retraining on like bleach, or other chemical things. But
we're trying to stay away from the bleach and the whole COVID thing after somebody
Yes.
recommended it. It was bad.
But you can use things like essential oils or household products as well. But if you can't smell anything, have someone around you who can kind of verify, like, yep, this is coffee that smells like coffee, or yep, this is an essential oil that does truly smell like this thing.
I think that's pretty cool. So here's the long hauler study thing. I think we have a clip that we were going to show a little bit about that. Nope. Okay, my mistake. Sorry about that, team. Okay, got it. So people can scan that and go learn more about a study that you've been doing. Is that right?
Yeah, absolutely.
Talk to us a little bit about that study.
Yeah, so we have 2 research studies ongoing. The first is just testing people's sense of smell with an olfactory or sense of smell test that we developed at KU. Because one thing you'll notice if you go to your primary care doctor typically and you say, hey, my sense of smell is down, nobody's really testing that because there's not a lot of accessible tests. And so our team is trying to fix that and making sure that our test is just as good as some of the others out there. And then the second part is that we are interested in folks who have lost their sense of smell in general, but particularly from COVID. And so if you think that your sense of smell is down, as you mentioned, you can go to either to the link or scan the QR code or email us at entresearch@kumc.edu, and we'd be happy to provide more information and make sure that you're eligible. And then lastly, we also have a study right now where we're investigating 2 different of those olfactory training or smell retraining protocols to see which is better. Or potentially if they're the same or neither is better. But we need people.
That sounds like a pretty cool thing there, and thank you for coming down and talking a little bit about that. Just a couple of quick words about our overall long haul clinic. It's pretty busy with our own patient referrals. There is some capacity. We anticipate opening up to the general public in the very near future. But to get there, you want to first see your primary care physician, get your treatment plan, have been in there for about 12 weeks. If things aren't getting better, we're happy to see you then. So ask that your patients we want you to begin with your primary care doc. If that doesn't work, then get a referral to the long haul clinic. Your PCP should know how to do that. Like I say, we'll be opening it up to people from the general community in the very near future. Anything you want to add to that, Hawk?
I mean, I think it's been greatly received, and there are a lot of patients who need referral to one specialty or another because of the continued long haul symptoms or the post-acute symptoms. So.
Yeah, great. Hey, Lee Norman, I did see yesterday some legislation around counties being able to do their own thing and not having to follow the statewide plans. Thoughts about that? Because I'm going to be honest, and I'm not trying to be nice to you. Why should I do that? But actually, I think Kansas has had a pretty good plan. I think our vaccine rollout has gone pretty well. But I'm seeing this kind of stuff. Oh, let county do their own thing. Talk to me about that. Uh-oh, you're muted there, sir. You're probably cussing me out in the background. I heard what you were doing. I could lip read.
That's a very smart question, Steve.
It's a shocker that I did that.
There's some political things kind of going on behind the scenes, and to be real honest with you, I do not want to see the baby thrown out with the bathwater. We've had 100-year-old public health laws that allow for certain authorities with the governor, with the secretary, and with the county health officers. There's some legislators that feel that there's been an overreach by the executive office and even by myself and the counties, and they want to grab back more control of it, quite honestly. We think it's ill-advised. We think that, well, I shouldn't say we, I think it's ill-advised. It shouldn't be just about 2019. Last week we had a big outbreak, I mentioned it, about syphilis. And we went in there the next day. Anything that slows down our ability to respond with assessment and treatment and case investigation is ill-advised. We have food outbreaks and things that we respond to immediately. So we've had mandatory isolation quarantine of mumps. And so it isn't just about COVID-19. Someday we'll be on the other end of COVID-19. And to turn public health authorities over to a legislative committee or an attorney general is ill-advised, I think.
Yeah, like as they would say in Star Trek, live long and prosper. My edit to that is, but don't do it at your neighbor's expense. Let's do it together, because that's really how we're going to get through this pandemic, because we all have to be kept safe. And I think fair distribution of the vaccine is key to that. And because one county, maybe they didn't take as much of a vaccine, maybe a lot of people had some hesitancy and turned it down, and therefore they have more vaccine. They want to go give it to others. Well, wait, we got to get the highest risk patients first. Otherwise, we defeat the whole point of vaccinating people in order. So talk to us a little bit about the vaccine hesitancy. How is that going for Kansas? And especially, I think, in some rural communities where I know that's been a little bit more of a struggle, or as published this morning in the New York Times, articles around hesitation in Native Americans. And Kansas has a Native American population we have to think about, as well as Latino and other populations. So how are we doing on that?
You know, I think we're average, quite honestly, in terms of hesitancy. And not only by rural versus urban differences, and you're right, Steve, pointing out that some of the rural counties have very low uptake, 35-40% of people getting vaccinated. A lot of the people, by the way, are kind of delaying it until they kind of see how it goes for a while. And, you know, I'm happy to vaccinate those people at any time. We do see it, and it's hard to separate out the difference between racial and ethnic groups and socioeconomic and just plain access. And I think one of the things that as we march through now into phase 3/4, we're going to have to continue to do really good down to the county by county, even neighborhood by neighborhood outreach, church by church, even outreach, to make sure that we have everybody have access. Because I do not want to confuse vaccine hesitancy with vaccine availability and access. So we have to continue to double down on our outreach to the communities that are struggling. Curiously, there's also cultures that seem to get less vaccine. One of them, the correctional facilities, for whatever reason, correctional officers are fairly low vaccine uptake. And very ill-advisedly, in my opinion, a lot of long-term care facilities staff are choosing to not be vaccinated.
I don't get that one. Yeah.
I don't get it either. And
I don't get it.
Yeah, they're at increased risk to acquire the illness and increased risk to transmit it. So it sets up whole layers of requiring periodic surveillance testing and the like. When I think they should get the vaccine, that's just me talking. That's what I do. But so we're just trying to win people over. Anytime that there's a chink in the armor with J&J or with like the AstraZeneca that you started the show with, then it gives people an excuse kind of to say, oh, that's bad. It's an experiment. So I think the best we do is just be straight up and educate the heck out of and be honest with people and tell them what we know.
We've had about 85 or 90% uptake here at KU, and we've seen the number of the absenteeism drop from work, from COVID, from 20 up to 100 people a day down to none or one or two. I mean, it's just remarkable, the effectiveness of the vaccine. And thanks to y'all for getting into all those nursing homes, because our nursing home admissions have dropped like a rock, too, for COVID-19. And I think that's why we had 4 patients in the ICU and only 1 on a ventilator, right? It's just a general downturn. What are you seeing in the wastewater these days? It pops up some places and turns into increased number of cases, and other places it'll pop up and then it'll die right back down again. We're not seeing much in the variants we've talked about. We've seen a slightly enlarging cluster down in Sedgwick County still of the UK variant, but it's been kind of steady to dropping off. When you look at the testing in the state, it's dropped even compared to last week when I reported. It's down to 2.7%. And you'll remember when we were 16, 18, 20. Oh, we got up to 30 or something for a while in Kansas City. So, yeah, that 2 to 3%, that's just awesome. So we're liking it. All right, let's see what we got out there.
I do have a student reporter question
from
K-State, and this is for Dr. Norman.
This is a good question. I read this one before, Lee. This is going to be good. We're going to have some fun.
Yes. Okay, so she is asking, she says, Manhattan, Kansas is kind of known for starting the party holiday fake Patty's Day, which is a full day of drinking and other shenanigans the weekend before St. Patrick's Day. So a lot of the normal bars are not participating this year, but there's a lot of videos and photos out there on social media of house parties associated with the event, and absolutely no masks in sight. Beyond just the mass gathering aspect of the event, the fact that people travel to Manhattan and back, is the KDHE at all concerned about this becoming a super spreader event and having major ramifications across Kansas?
All right, so kind of a party time at K-State. I'm sure that's the only college in the country that has that. This certainly doesn't go on anywhere else. But could that be a super spreader event, Lee Norman?
Oh, it absolutely could be. The only good thing I can say about it is that there's in that area, statewide, et cetera, there's less circulating virus, so there'll be less people coming and going that have already acquired it probably than if we were having this conversation, 2 months ago or something. But that's a really bad idea. And the reason is that most of them are young people, are healthy, and they have not been vaccinated. So for them, nothing's changed in terms of their risk. It's a really bad idea. I know they're not going to go there and wear a mask. I just don't think they should go. These kind of gatherings are by definition high risk for super spreader events, and then they go to the wind in terms of going back to their homes and families and whatnot. So it's just a bad idea, and I think it's irresponsible for the business owners.
Hawk, what are your thoughts?
Yeah, I mean, I think it's a bad idea. We've seen it time and again with young people because, just as Secretary Norman said, their risk of severe disease and death doesn't change. They are certainly at lower risk, but they still are at risk. But they still have that ability to transmit to other people who could be more at risk. And anytime you have a large gathering of people who are unmasked, being close together, we know that alcohol will reduce your inhibitions anyway. So even if they are wearing masks, more than likely those things will come off at some point. And just kind of continuing to gather, and it's a bad idea, and it's high risk.
Jess?
Laura asks, for a person who has lost their sense of smell, is a second COVID infection likely to cause a more dangerous infection?
Ooh. That's an interesting question.
Yeah.
And I'm going to follow up with that. So any thoughts about that? Is a second COVID infection going to be more dangerous because you lost your sense of smell before?
Yeah, so we don't have any good data on the second infections. In general, in terms of the severity of the COVID infection, what we've seen and what's been documented in most of the studies from around the world actually is that the more severe your sense of smell loss, the less severe the clinical disease is. And so that's something that I might offer also to the college students that are like, I'm going to be fine. My symptoms will be minimal, if any. I do see patients in my clinic who are young, healthy, 18 to 30-year-olds who had a very mild course of disease, and now they have no sense of smell. And, sense of smell is easy to say, well, at least it's not your eyesight, et cetera, but it's so important for safety, so important for nutrition, just enjoying the things that you're eating, perceiving flavor in food instead of everything being bland. So I think those are the types of things that folks should be considering as well.
Yeah, I think it's interesting, and please correct me if I'm wrong. I thought a lot of the mechanism of the pathogenesis of that anosmia, the lack of smell, was due to more of the sustenticular cells, or those cells that support those olfactory nerves. And it seems to be like it is a direct viral infection of those areas because it happens early. And it's not like in the lungs where we see people's lungs fill up with fluid in that inflammatory state, but it's early on. And so that's a really good question. I think you are certainly going to be susceptible to continued viral reinfection if you get reinfected with the virus. I don't think we know what happens, but that's a good question.
How long can you take nasal steroids?
Yeah, so how long you take them is it depends on what the reason that you're taking them is. But for a lot of my patients that have chronic inflammatory sinus disease, so things like allergic rhinitis or chronic sinusitis, we have those folks on nasal steroids long term.
Yeah, I started with my nasal allergies when I was 22 years old, 23 years old, driving to, I can tell you the day, it was March the 13th, and I sneezed 23 times in a row, and I had never had a problem with allergies, nasal, and then boom, it hit right there. I was at med school at Mizzou, go Tigers, and I was driving home for spring break, and I had to stop because I had to pull over. I had to sneeze, and it wouldn't stop.
Wow.
And then, I've been on nasal steroids long-term since, and, granted, it was a couple of years ago, but I think I've been doing not just, maybe like 34 years ago. So
You've turned out fine.
Yeah, some people would debate that.
Sean wants to know from Dr. Norman, He says, I have a 16-year-old daughter. Will there be a way after May 1st to schedule an appointment for 16 and 17-year-olds and guarantee a Pfizer vaccine, as Pfizer is the only one approved for 16 and 17-year-olds?
Oh, great question, Lee Norman.
Well, I don't know about the exact date because it depends on how much vaccine we get in. So we've modeled it out and feel like that everybody that will want a vaccine, 16 and older, will get one by May 1. But I'll predicate that on how much vaccine we get, and to the earlier question, what the percent of people are that actually get it. But it is approved for that group, and depending on if they fall in phase 3, 4, or finally more the general public and young person population 5, well, hopefully it will be available to that person by May 1, depending on the supply available coming to us. And yeah, you're right on the selection of the product. There are lots of tests. There's some clinical trials going on now at all ages of young people below the age of 16, even down to babies and children. And so I don't know the pace of that. I think it would be unlikely to have any approved products before May 1 for those under 16. But I just don't have that information yet because nobody does.
You know, just to say, Moderna has now announced they're going to be doing a study on children 4 to 11 years of age. Or,
Yeah.
Is that right? Did I have that right?
Or even younger.
Younger. It was younger than
Yeah.
that. I just read that. I forgot the age already. But it was young kids.
6 months maybe.
So now we'll be really covered, right? From like 6 months all the way up until 16 or 18. And that way we'll have the data around the vaccine safety and efficacy in young children. I think that'll be really important information.
Lori wants to know, how are people supposed to prove they have a medical condition or are a personal care provider?
You know, that was a great question. I think, Lee, as we talked at the beginning of the show, that's going to be really kind of personal responsibility. As you mentioned, they could bring a pill bottle, they could bring a note from their physician, they could bring a copy of their prescriptions. But I think for most of us, we're going to say, especially in these mass vaccination clinics, you're just going to rely on personal responsibility if people have to come and get their vaccine. So I'm asking that to Lee. Is that a fair statement?
I think so. We'll provide some guidance this week, and also we will consult with the vaccinating sites as to what's practicable, because especially the mass vaccinating sites. I went through one yesterday that does 1,750 vaccines a day, and one of the things you don't really want to do is shuffle through medical records and all sorts of things that slow down the process. We want to keep that moving. So is it really worth it to have a really tight process for validating? And I think the answer to that is no. But I would like people to, if they have anything. I mean, everybody's got a bill or something they can hang on to. I would think that it would be, but I think it would be a really good time to talk to your care providers. If they want to write it on a prescription pad, then so be it. But I don't want to burden the healthcare providers.
Another question is, if we're going to have enough vaccine between now and May 1st, that's 6 weeks away, when do we just say, it's just open season, let's get everybody vaccinated?
Well, we'll say that exactly at the right time. Whatever that is.
That was an exactly right answer to that exactly terrible question.
And I know that we're trying to, split hairs here on medical conditions. The things that have been shown time and time again to be at the highest risk of adverse outcomes or suboptimal outcomes is obesity and diabetes. And some of these other conditions, may put you at higher risk, but may not. But really, obesity and diabetes has shown time and time again to put you at further risk of those adverse outcomes. Even when you look at countries of mortality rates, and certainly the rate in the United States of mortality in the United States is quite a bit higher than, say, in some of the Asian countries, and that correlates with obesity rates as well. So, most of the time it's not too hard to find obesity or diabetes mellitus. Those are the major two. Now, certainly there are blood cancers like lymphomas or leukemias that put you at a higher risk that you need to get vaccinated for as well, which you should talk with your provider about. But even in those cases, we would be concerned that you may not mount a good response to that vaccine in general. But again, obesity and diabetes continue to be major issues and increase your risk of hospitalization and death.
Pamela says she's so glad that you're addressing this long haulers topic today because she is a long hauler, has lots of questions. She wants to know if being a long hauler might be considered a disability at some point. A lot of long haulers have had to leave their job because they can't physically keep up anymore.
You know, I think it's like a lot of conditions in medicine where, having been doing this for many years now, there are new conditions will come about, and over a period of time, it is recognized that you can no longer work. So I would not be surprised if that were to be the case around long haul syndrome, especially the more and more time that goes by and the more evidence that's accumulated around that. And so, Dr. Norman, I'd be sympathetic to that as a point of view. I mean, it's not unlike other diseases that have cropped up in the last, X number of years that eventually we recognize can have long-term consequences and result in disability.
Yeah, I've met with HR professionals, an organization of human resources professionals, and also an organization of attorneys who do disability work, and not to render an opinion so much as just as to provide information and facts. And there's a body of law that will come out of this, and policies and around disability and workers' compensation. Because the other big issue that it's a can of worms, quite honestly, is how did the person acquire the infection at their job site, and is it considered a compensable workers' compensation injury, quote unquote, or illness? And those have not been answered yet, I assure you, and this will take quite some time to work through those processes.
Jackie is asking you all, when can we do away with masks on students in schools, especially elementary students? What do you think?
Oh, gosh. Okay. When can we step away from masking? I'm going to give you my opinion. Not yet. And I don't know when the date will be, because I think it depends entirely upon how the pandemic progresses. Hawk, what do you think?
I agree. Not yet. I mean, we would all like to not have to be wearing a mask in certain situations.
Yes, that's for sure.
There still continues to be this line of thought, which I think is incorrect, saying children don't spread the virus or they don't get infected with the virus. There are a lot of caveats to that information and that data, one of which being children a lot of times certainly will not mount symptoms. And so they're not getting tested. They haven't historically been tested the same rate as adults. Also, what happened? Why weren't children getting it, say, in the shutdowns? Well, they weren't all together. They weren't meeting in groups. Yeah. So their risk of getting the infection was smaller because of that. So there are a lot of caveats to that line of thinking that children just don't get infected as much. We would all like it, but we know in schools, especially if you can't de-densify and have that spacing, that they still can be at risk, and that is one of the things that has kept teachers and people in the schools and children safe, is doing those infection prevention measures. So I think that's a good answer. Not yet. We would all like it that day when we can, but we don't have a good idea as to when that will be.
Dr. Villwock, do you have thoughts about that? I mean, you have to wear a mask all the time in the operating room.
Yep. So, I mean, I have a school-age daughter myself, and, I think that the silver lining that we try to talk about at home is that, number one, a lot of times she doesn't even realize that she's still wearing it, so it's not super bothersome for her. And we have also noticed that, last year when she was in kindergarten, she was coming home with a cough, like, every other week. And this year it's been, nothing. So, I think the long-term lessons are just improved hygiene at school, and hand washing, et cetera.
Makes a difference.
Makes a huge difference.
Yeah.
But yeah, I completely agree that, the mask wearing, I think for now is something that's going to be here to stay, until we have some real compelling evidence that it's no longer necessary.
Would you ever go into an operating room and operate on a patient without a mask?
Nope.
No. Doesn't that just sound awful?
Yes.
And we still have those mask doubters out there. I keep saying to them, we don't have any cases in the hospital of getting COVID from our COVID positive patients. I wonder why that could be. Oh, wait, masks. And surgeons, you always wear masks.
Yep. There's a lot of very meticulous rules which we follow to the letter, to keep our patients and ourselves safe.
Yeah, it totally makes sense. Okay, Norman, you've had your expert panel weigh in. When can we take the masks off in schools?
Oh, here's a clever response. Not yet.
That is so original.
We will really, I think we'll rely a lot on the CDC and American Academy of Pediatrics, because there's a lot of studying going on. For example, distancing. We do believe that social distancing, and we have picked the 6 feet and greater. But there's some recent studies that are showing that there's no difference between 3 feet and 6 feet of social distancing in a classroom setting. I think we need some guidance on this. We do know that this notion that kids don't wear masks well, it's like putting it on a pet raccoon or something, kids wear masks really well. And so I think we should not be quick to abandon them.
I'm with you. And the other thing, just to say it out loud, how much influenza do we have this year?
None.
None. Are you getting any at the state level?
We have an occasional positive test. You'll recall that we do this multiplex test that tests for both influenza A and B and COVID-19 when a COVID-19 is ordered. So every now and again, we pick up an influenza that has symptoms. Obviously, probably the person has similar symptoms that are not discernible, COVID-19 versus influenza, but they're very, very few, and almost no hospitalizations around the state, which is very unusual.
Ashley asks, why are vaccines not available at CVS, Hy-Vee, and Walmart in Kansas like it seems to be in the surrounding states?
Ooh, I think they are available. There's just not a lot of them, Dr. Norman.
Yeah, they're available in all three of those. Matter of fact, Hy-Vee has been a recent terrific partner in taking their mobile vaccine platform to counties and regions that are having difficult time getting access to the vaccine. All three of those are partners through the Federal Pharmacy Partnership Program, all three of the ones that are mentioned, as well as Dillon's and Kroger's and then the large consortium of independent pharmacies. So there's the pharmacists are going to be the single biggest category of vaccinators, and all the ones that were asked about are partners in the state of Kansas. But as per Dr. Stites, they don't have the vaccine that they need to, as they would like.
I think we can all say they have been approximately a very good partner and done a great job. And we should be thrilled that there are that many pharmacies out there helping do vaccinations, because as the number of vaccines roll up to higher and higher numbers available every week, we're going to need everybody to get those vaccines in arms. And the sooner the better, because we know that's what's going to lead us back to Kaufman, Arrowhead, and a lot more sense of normalcy, sporting, the whole 9 yards. Last question.
Okay, Melissa says she's heard Dr. Stites and Hawkinson say studies suggest the possibility of you infecting others with the virus if you have it seems to go down significantly if you've been vaccinated. Is that true for all the variants? Is it an average? Is it across the board? Or do you know?
Yeah, we don't really know a lot of information about that yet, Hawk. But we know that it goes down in some preliminary data from, I think, the Johnson & Johnson and AstraZeneca studies, that really the rate of communication of active COVID goes down by 2/3, 3/4, and maybe more.
Yeah, and the real world experience with Israel. And again, these are studies looking at people who have asymptomatic infection, meaning they're infected, but they aren't showing any symptoms. That was significantly reduced. So we are extrapolating from that, because we know that you spread a lot of the virus when you are asymptomatic. We know that was a large mode of transmission, or before your symptoms. So because of those lower numbers of people who don't have symptoms, we are extrapolating that there will probably be less transmission. We don't know about the variants yet because there's just not enough information about these variants. In particular, the variant identified in South Africa, and I believe also in Brazil, the P1, both have a certain mutation, the 484 mutation in that spike protein that makes it a little bit better binding to the human receptor, and just making it then certainly more transmissible. So we just don't know. And that mutation also may not make the vaccines that we have, the current vaccines, their immune response as great as compared to the original ones.
All right. Hey, tomorrow is actually a really special show. It marks our 250th episode, and it's our birthday, because 1 year ago tomorrow, I think, we had our very first program. We've invited two special guests, U.S. Senator Jerry Moran from Kansas and U.S. Senator Roy Blunt from Missouri. We are delighted to have these two honorable men working back on our program, because these have been two folks who have done a great job around this pandemic, and we appreciate the great work they've done, and it'll be great to have a conversation with Senator Moran and Senator Blunt. Together, we're going to look back over a year of this pandemic, and we're going to look ahead. We hope you can join us. Lee Norman, final thoughts from today.
Yeah, back to that K-State question. we can't let our guard down, because COVID-19 is not gone and it's not forgotten. And you just have to keep remembering that. Yesterday, we recorded 470 new cases that had come in since Friday morning, 11 new deaths, and more hospitalizations. So it is not the time to let our guard down. When people get vaccinated, we'll have a different conversation. But until which time, do not let your guard down.
Final thoughts from today from you, Doctor?
I think, the take home that I hope people get from me is just that if you're having symptoms that can't be explained, that you've had COVID, it's important to get those checked out. There can be overlap with other things that you'd want to know about if they're going on in your body. So, reach out to your primary care doctor, reach out to us. We'd be happy to see you and help you as best we can.
Yeah, I think one birthday a year is enough for me. I don't know that we need to call. I'll stay 35. Just a quick flu update, because we had talked about influenza, and as of March 6th, per the CDC data, out of clinical and public health laboratories, there have been 1,061,000 tests for influenza being run, and only a total of 1,764 cases that have been identified. So that's
really good.
0.16% of those testings.
Wow, that's awesome. 35, then I'm 38. All right, folks, listen, I want to say a special thank you to Lee Norman, always a great public servant out there doing the duty and working so hard with KDHE. I want to thank Dr. Jen Villwock for being here this morning. I got her name right that last time, and one of our outstanding ENT surgeons. Welcome back, welcome back anytime, and of course, Doc Hawk. Hey, listen, one of my favorite Star Trek episodes ends with a captain saying, "Let's fly." It's not time yet. You don't want to fly before we're ready. You don't want to fly out of here and take off your mask and act like things are normal when they're not, because you don't want to crash. Crashing is really bad around COVID-19 because we can fly very soon as we get folks vaccinated and we make sure we can stay safe. We still keep our distance. We're still wearing masks right now. It's not forever, but it is for right now, because it's not time yet, but that time's a coming. We want you to be safe until then. We want to see you tomorrow at our anniversary show. And until then, remember, there's still no place like home.